Welcome back to the deep dive, where we cut through the noise, stack up the source material, and get right to the high yield information you need to be well informed, or in today's case, maybe well reimbursed.
Exactly. We're diving deep into, a classic emergency department reality. We are absolute masters of critical care delivery. I mean, that's why we thrive in a place like Banner Gateway Medical Center.
Right. It's organized chaos.
It is. But when it comes to the documentation, the billing side of things,
Mhm.
we consistently let our highest acuity work go unnoticed.
Mhm.
And that is just the silent killer of, well, getting paid for what we actually do.
It truly is. It feels like we put in 100% of the effort and then we just kind of accept 50% of the credit.
hmm
Okay, let's unpack this with the scenario that I think is just painfully common at a busy ED like BGMC, especially on like a Saturday night.
Oh, yeah. Lay it on us.
All right. You're 2 hours into your shift. Triage rolls in a 78-year-old acute severe CHF exacerbation. And I mean
Pitch
severe.
black.
Persistently tachycardic at 1:30, breathing 35 times a minute. Sats are dropping to like 88% on their HOMO2. They're drowning.
Circling the drain. You see them from across the room, and you just know.
You know. So you immediately flag the chart, you grab a nurse, and you spend the next 45, maybe 50 minutes completely, totally dedicated to them.
And in those 50 minutes, you're not just, putting in orders and walking away, right?
Oh, way.
You're actually at the bedside, putting them on BiPAP. You're starting an IV Lasix push. And then 10 minutes later, you're probably adding a second push because the first one did nothing.
Didn't touch it.
You're slapping on nitro paste. You're fiddling with the BiPAP settings every 5 minutes. Then you're running back to the computer to see the EKG, then back to the bedside. Then you check the chest x-ray.
Which just screams pulmonary edema. It's a total whiteout.
Exactly. And you're calling cardiology for admission advice. You're talking to the family. It's all hands on deck.
Precisely. It's 50 minutes of dedicated, high complexity, life-saving work. You avert disaster, the patient stabilizes enough for admission, maybe to telemetry, and they avoid the ICU completely, which feels like a win.
A huge win.
But then you go to chart it, and you're exhausted. You think, well, they didn't get intubated, they didn't code, so you slap on a basic level 5 EM code. Maybe you throw in a quick procedure note for the BiPAP, and you completely, totally miss the chance to bill 99291.
And that right there, that moment is where the financial and, frankly, the professional reflection of your work is just lost.
Yeah.
You spent 50 minutes providing what is called critical care time, but you documented it as a level 5,
Which is a fraction of the value.
a tiny fraction. That difference hugely impacts your RVUs,
Yeah.
your relative value units, which is the metric they use to figure out payment for what we do. And look, this isn't just about money. It's about accurately representing the insane acuity and cognitive load that you just managed.
It is absolutely the mental hurdle. We're wired to focus on the clinical outcome, right? But we have to train ourselves to see when that complexity crosses the documentation threshold.
And our mission today is simple. It's targeted specifically at our colleagues at Banner Gateway. We want to make sure you understand what critical care actually is,
Right.
how to spot it in those crazy resource-strapped moments, and, how to get proper credit for the work you are already doing. We're going to highlight where those missed opportunities are hiding in plain sight, so you stop leaving your hard work unnoticed.
Okay, so let's start with the absolute foundation. We said we have to stop confusing critical care with just coding or trauma. I mean, those big dramatic cases are easy, right?
They flag themselves.
Yeah. But the bread and butter critical care that defines an average ED shift is often invisible to us, the providers doing the work. So how do we draw that line?
We have to shift our thinking to focus on one concept: risk. Critical care is defined by 2 key clinical criteria, and then after that, a time threshold. You absolutely need both of those clinical things to justify the time component when, an auditor comes knocking.
Okay, so break it down. Criterion number 1. What makes a patient critically ill in the eyes of, the people who actually pay the bills?
Criteria number 1 is the critical condition.
Okay.
The patient has to have an illness or an injury that acutely impairs one or more vital organ systems,
Okay.
such that there is a high probability of imminent or life-threatening deterioration in their condition. That phrase is what we need to, tattoo on our brains.
High probability of imminent deterioration.
Yes, that's your justification for everything that follows. That's why you had to give your aggressive, dedicated, high-complexity management.
So it's not about what actually happened to the patient in the end. It's about the potential for disaster when you first saw them. If you saved them from deteriorating, it doesn't mean the risk wasn't there.
Precisely. If they were fine, you wouldn't have spent 45 minutes glued to their chart and bedside. The critical condition is what demands your continuous focused attention. And we manage this kind of acute impairment, every hour in the ED, but we just don't recognize the coding weight it carries.
So what are these vital systems we're talking about? I think most of us, our brains immediately jump to, heart and lungs. But that's too narrow, isn't it?
It is way too narrow, and this is where we miss huge billing opportunities. The source documentation is really clear on this. It lists what we can kind of affectionately call the big six vital system impairments.
Okay, let's hear the list.
So we're talking about central nervous system failure. So that's things like an acute stroke, status epilepticus, or severe delirium, maybe meningitis where the GCS is really affected.
Yeah, I got it.
Then there's circulatory failure. That's your hypotension, your shock states, NSTEMI, unstable arrhythmias, the obvious stuff. But don't forget renal and hepatic failure. These often present more subtly, but they demand really aggressive intervention.
Right.
Of course, there's respiratory failure, severe asthma, COPD, pulmonary edema, and this is a big one, metabolic failure.
Okay.
Think DKA with a pH less than 7.25 or severe hyperkalemia or, a complex overdose. And finally, severe trauma and even certain psychiatric conditions, but only when aggressive intervention is needed to prevent life-threatening harm.
Wow. That list alone broadens the scope massively. That covers, I don't know, at least 30% of our daily high acuity volume at BGMC.
It should. Which brings us to the second criterion. You have to perform a critical intervention. This is the active management part.
This is what you do.
Yes, you need to show that you're making decisions of high complexity, specifically to assess, manipulate, and support those failing organ systems, and, crucially, to prevent further life-threatening deterioration.
So this is the difference between, say, just watching a stable patient versus actively titrating their meds, messing with their oxygen, starting a drip, or, ordering that massive PE workup stat.
Exactly. It's the constant reassessment. It's the dynamic nature of your plan.
Yeah.
You're not just putting in an order and walking away. You are dedicated to that patient's physiology until the threat of imminent collapse is gone. That high-complexity decision-making is the cognitive service we are billing for.
And finally, the third piece of the puzzle, the one that makes this billing so unique and, honestly, kind of a pain, the 30-minute threshold.
Right. Critical care is fundamentally time-based. This is so different from other EM coding where it's usually about the complexity of the medical decision-making. Here, you have to spend a minimum of 30 minutes of total duration.
So just over 29 minutes.
Just over 29 minutes providing this dedicated critical care. If you spend 29 minutes, it's a level 5 chart. 30 minutes, it's $992.91. That 1 minute can be worth hundreds of dollars in reimbursement, and it more accurately reflects what you actually did.
So let me just reiterate a point we made earlier because I think it's so important. Critical care is defined by the patient's condition and your high-complexity interventions. It is not defined by the location or the final outcome.
Absolutely correct. We are providing critical care in the emergency department. It is billed the exact same way, whether that patient goes to the ICU to the floor or, in some really rare high-stakes cases, even discharged home. The disposition doesn't retroactively downgrade the crisis you just averted.
You mentioned that discharge to home thing is rare, and I feel like we need to add a little nuance there. I mean, if the rules don't forbid it, why is it such a problem with insurers?
Yeah, it's a huge audit flag. Insurers, auditors, they look at that phrase, imminent risk, and then they see the patient walked out an hour later and they question it.
Right. They're like, how bad could it have been?
Exactly. They argue that if the patient got stable enough to go home that fast, the initial risk wasn't truly life-threatening. So as a rule of thumb, even if the care was critical, you should probably only document CC time if the patient is admitted, transferred, leaves AMA, or, goes to hospice.
So fighting for a discharge to home critical care billing is kind of a losing battle.
It often is. And we want to focus on high-yield compliant billing,
Okay, let's unpack the clock now. We need 30 minutes of focus time. Is that just continuous time, like standing right at the bedside with a stopwatch? Or is the clock still ticking while I run over to the computer or talk to the consultant or...
This is where the flexibility of the cumulative time rule really saves us. That 30 minutes does not have to be continuous, thank goodness.
Okay.
It can be cumulative. You can add up all the little bits of dedicated time from the moment you start seeing the patient until you finally hit sign on the chart.
I always think of critical care time as just the hands-on stuff. But so much of the real work of an ER doc is cognitive, right? The interpreting, the planning, the coordinating.
Precisely. And that cognitive work counts. But, and this is a big but, the key qualifier is dedicated full attention. For any minute you count, you must be devoting your full attention to that critical patient.
So you can't be sitting in the doc box reading EKGs on 4 other patients while claiming time for the one critical one.
Exactly. The time has to be non-concurrent.
So let me get this straight. Those 15 minutes of initial stabilization, plus the 10 minutes I spent on the phone arguing with the ICU attending, plus the 8 minutes I spent staring at the complex CT results, and then the 17 minutes it took me to type up that insane, constantly changing management plan. That all counts, even though I wasn't glued to the bedside.
Absolutely. It all counts. The time counts, even if you're not at the bedside.
Yeah.
But you have to be on the floor or unit and actively working on that specific patient's case.
Let's listen at what counts, because this is where a lot of the confusion is.
Yeah, what are the high-yield activities we have to remember to count?
Okay, number 1, obviously, direct bedside care. Face-to-face, time, exams, managing the patient. That's the easy one.
Right.
2, diagnostic review and interpretation. Time you spend reviewing labs, looking at imaging, or interpreting the cardiac monitor, serial EKGs, that kind of thing. That 5 minutes you spend staring at a chest x-ray showing worsening pulmonary edema, that's high complexity decision-making time.
Okay, that makes sense. 3, consultation and coordination. Time you spend talking about the patient's care with consultants. Cardiology, GI, ICU, or with your nurses, your RTs, anyone. And 4, and this is the big one we always forget, documentation. The time you spend actually typing your chart, putting together the complex story, listing your interventions, that counts towards your total critical care time.
That documentation piece is huge for us at Banner Gateway. If it takes me 15 minutes to accurately write down the story of a septic patient's crazy hour-long course, I should count those 15 minutes.
You absolutely should. It is part of the service. And we also have to remember the family discussion rule.
Oh, right.
Time spent talking about treatment with the family counts only if the patient can't make decisions for themselves. They lack capacity. And you have to document that explicitly, why you had to talk to them, what decisions were made. Just giving a simple update to the family doesn't count.
Got it. Okay, now for the hardest part, the exclusions. What stuff do we do that's essential, but we have to subtract from the total CC time?
This is the #1 reason providers either miss the mark or, worse, trigger an audit. The rule is simple. Any time you spend on a procedure that is separately billable must be subtracted from your total critical care time.
You can't double dip.
You can't bill twice for the same 5 minutes.
This requires us to wear 2 hats at once, doesn't it? The clinician hat saving the life and the accountant hat with a mental stopwatch. So what are the big procedures we have to be really careful about subtracting?
Well, the list is pretty long, but the big ones we have to mentally carve out are intubation, CPR, central lines, A-lines, chest tubes, cardioversion, LPs, even a complex LAC repair or fracture care.
So if I spend 15 minutes stabilizing a patient and then 15 minutes putting in a central line, I have to subtract that 15 minutes for the line, which leaves me with only 15 minutes of critical management time.
Exactly. And a separate procedure code for the line.
Wait, okay, I have to challenge this because it just feels so counterintuitive when you're in the moment. Let's use the CPR example again.
It's the perfect example of why the rule exists. The time you spend actually doing CPR is excluded because you bill for the CPR procedure code, 92950. But the critical care time would be the time you spent managing the patient before they coded and the management after you get ROSC.
ROSC, return of spontaneous circulation.
Right. If that remaining time adds up to more than 30 minutes.
Okay, so patient comes in hypotensive. I spend 20 minutes managing pressors and fluids. Then they code. I spend 15 minutes on CPR. Then they get ROSC, and I spend another 15 minutes on post-ROSC care. My total critical care management time is 75 minutes, and I bill the CPR separately.
Exactly right. You separate the components. Now, here's the financial warning we talked about, which really shows why this is so important. What if the patient comes in dead and stays dead? You do 40 minutes of continuous CPR, and then you call it.
If they stay dead, no critical care time is billed. Because like you said, CC time is for managing imminent deterioration, not for doing procedures on a patient who's already deceased.
Correct. That encounter should be billed as a level 5 EM code, plus the CPR procedure code. Now look at the RVUs. Billing CPR plus a level 5 gets you about 10.6 RVUs. If you mistakenly just bill that 40 minutes of work as critical care time, you only get 6.36 RVUs.
Wow, that's almost a 40% loss for the exact same work.
It is.
So this is where it gets really practical. You're saying that correctly identifying and carving out that procedure time and then billing it separately with a level 5 if the patient dies is crucial. Focusing only on the CC time code can actually mean you get paid less for more intense work.
Absolutely. The procedure codes themselves carry a lot of RVU weight because they're high skill, high risk. When you combine them correctly with the cognitive EM or critical care management part, you're accurately representing the total work you did. Separating the hands-on procedure from the brain work is the key.
Okay, that clarifies the rules and the financial reality. Now let's do a rapid fire round. The common ED misconceptions. These are the mental blocks that stop us from even thinking about critical care at Banner Gateway.
Let's do it. We need to normalize the confusion because these myths are just so pervasive in ED culture.
I'm ready.
All right, let's tackle the 4 biggest hurdles that stop clinicians from documenting their time right.
Myth number 1. The patient must be intubated to qualify for critical care time. No tube, no crit care.
False. So
Wow.
false. I mean, yes, intubation is a clear sign of respiratory failure, but so much of our most complex critical care is the management we do to prevent intubation.
Right.
Think about metabolic crises, DKA with a pH under 7.25, severe hyperkalemia where you're giving the whole cocktail D50, insulin, calcium, bicarb, or a severe COPD on BiPAP who you're just blasting with nebs. All of those are acute organ system impairments. They all require high-complexity decision-making, and they often take way more than 30 minutes.
So the successful management without a tube often shows more complex decision-making than just tubing them.
It really can. You are manipulating the circulatory system to prevent cardiac arrest. That is the definition of critical care.
Okay. Myth number 2. The patient has to go to the ICU. If I stabilize them and they go to the floor, or God forbid I send them home, it wasn't critical care.
False. We touched on this, but it's so important when I say it again. The disposition does not matter. The care is defined by the patient's condition and your aggressive intervention in the ED.
Right.
The fact that you stabilized them so well they were safe for the floor doesn't cancel out the severity of their presentation. That was the outcome of your critical care. Now, auditors might question it, so we stick to documenting it for admitted or transferred patients for practical reasons, but clinically, the work was critical.
Got it. Myth number 3. Critical care is only for trauma or codes. If it's medical and not a massive stroke or STEMI, it's probably just a routine level 5.
False. This myth causes us to miss so much high-acuity medical care. I mean, we stabilize sepsis constantly at Banner Gateway. If a patient has a severe infection, even if they're not in full-blown septic shock yet, but they need aggressive management.
Like what?
Like, say, they need 2 or more IZ antibiotics, they have altered mental status, their heart rate is stuck over 120, or their lactate is over 2.0. That is critical care management. You are dedicated to managing that distributive process before they completely collapse.
That initial sepsis bundle, chaos, getting the fluids, the cultures, the antibiotics, calling surgery, that can easily take an hour of high-focus work.
It absolutely does. The data confirms that having multiple interventions fluids and multiple antibiotics or signs of organ dysfunction like a high lactate or AMS, that's enough evidence of critical care management no matter what their blood pressure is.
Okay, final one. Myth number 4. The final diagnosis determines the CC. If the stroke alert was negative or the chest pain was just stable angina, then the time doesn't count.
False. It's the risk and the management based on the initial presentation that matter. A stroke alert that requires you to drop everything, get rapid imaging, and have a consult about TNK. That is critical care time.
Tenecteplase, place, the clot buster.
Right. You are literally dropping everything
Mm-hmm.
because that patient has a high probability of immediate life-threatening brain damage. You are weighing the massive risk of a brain bleed against the benefit of busting the clot. That is high-complexity, time-sensitive decision-making.
So even if we decide not to give TMK, or it turns out to be a mimic, the hour we spent managing that acute critical risk and ruling out disaster, that still qualifies.
Yes, the clinical services were necessary to avert a critical deterioration. It's the same for a patient with severe asthma who gets way better after epi and IV steroids. It was still critical care because of the life-threatening risk when they first showed up. You have to focus on the presentation, not the outcome.
Okay, this is the high-yield practical section. We've defined the rules, we've cleared the mental debris. Now let's talk about those cases at BGMC that look conceptually stable on paper after you've worked your magic, but they took intense, dedicated attention for way more than 30 minutes.
These are the charts that just slip through the cracks.
Yep.
We need to mentally program ourselves to see the billing triggers. When you order one of these complex interventions, that should be a little flag in your brain to start the critical care clock and make sure your documentation reflects that complexity.
Let's start with the things that cause immediate distress. Number 1, respiratory issues.
Okay, the common exacerbations. COPD or asthma. This qualifies if the patient needs BiPAP CPAP. That's an obvious trigger.
Mm-hmm.
But also, if they need continuous nebulizers I mean, you're giving one right after another or more than 3 separate treatments, and they're still in distress. Plus, you had to add other high-risk meds like IV Sonidrol or IV magnesium. If you're doing that level of aggressive, sustained management, you've easily met the criteria. You are actively preventing intubation.
And back to our first case, the CHF exacerbation.
Yep. CHF qualifies if they're persistently tachycardic, need a lot more oxygen than their baseline, or if they need IV Lasix with aggressive monitoring. If they're bad enough to need an IV nitro drip or BiPAP for flash pulmonary edema, that's explicitly critical care time. You're managing acute pump failure and trying to prevent respiratory collapse. Document that tachycardia and why you chose Lasix versus nitro.
What about just simple hypoxia?
A new diagnosis of hypoxia or needing more oxygen or having a sat less than 80% on their usual oxygen. That's an acute organ system failure. The time you've been chasing down the cause, looking at the x-ray, running the VQ scan, and stabilizing their oxygenation for over 30 minutes, that qualifies.
Moving on. Number 2, metabolic and endocrine crises. These are often complex titration cases.
VKA is the perfect example.
Right.
They qualify if their pH is less than 7.25 or their glucose is over 600, and you treat them with an IV insulin drip and more aggressive fluids. Starting that drip and titrating it requires constant reevaluation of their lights, their acid-base status, their glucose. You spend an hour making sure you don't cause cerebral edema or drop their potassium too fast.
That titration is the high complexity part.
That is the high complexity decision-making. And then there are the high-risk, low-volume emergencies, like hyperkalemia.
Right.
Hyper-K qualifies if you treat it aggressively with the classic triad, D50 insulin, calcium, and telobicarb. You are dedicating your time to watching the EKG for signs of cardiotoxicity and aggressively shifting that potassium to prevent a fatal arrhythmia. On the flip side, if the potassium is profoundly low, like under 2.5, and you're giving IV potassium at a high rate while watching the EKG, that also qualifies.
Okay, next category. Number 3, cardiac and hemodynamic cases, the ones that aren't just a simple chest pain rule-out.
Acute GI bleed is a massive opportunity for missed CC time. It qualifies if the patient is hemodynamically unstable, so a blood pressure less than 90 or a heart rate over 100, or if they have a mental status change, a hemoglobin less than 7, or they need a blood product transfusion.
PRBCs, platelets.
Right. That initial resuscitation phase, ordering the type and cross, calling the blood bank, getting GI on the phone, watching for rebleeding, that can easily take 35 minutes of dedicated attention. You are managing acute, life-threatening circulatory failure.
Okay, let's detail the hypertensive emergency because that requires such careful titration.
It absolutely does. This qualifies if their systolic is over 230 or diastolic is over 130 with signs of end organ damage like CVA symptoms, acute CHF, new chest pain, and you have to give 2 or more doses of IV push meds or start a drip.
Labetalol ×2 or a nitro or cardine drip.
Exactly. The decision-making is so complex. You have to watch if their creatinine is jumping, if their stroke symptoms are getting worse, and why the first dose didn't work, all while trying not to drop their pressure too fast. That minute-by-minute titration is the core of the high-complexity decision-making that justifies the CC time.
And what about managing rapid arrhythmias?
AFib with RVR, rapid ventricular rate, qualifies if their rate is over 150 at any point and you need continuous IV medications like a diltiazem drip or you have to do an emergent cardioversion. You're actively trying to control the rate to stop them from decompensating into shock. The time you spend setting up that drip and titrating it is critical care time.
All right, moving on to number 4, neurologic and CNS emergencies.
We already established that a stroke alert is CC time, even if it turns out to be negative. Just document that you considered TNK-TPA. Well, let's talk about the general altered mental status patient because we have to be really precise here.
What's the rule for documentation?
Do not use altered mental status as your critical diagnosis. It's too vague. It's insufficient. If the cause is metabolic, you need to write acute metabolic encephalopathy. If it's hypoxia, write hypoxic respiratory failure. Use definitive language that points to the organ failure. And as a general rule, a GCS of 12 or below is always critical care because of the risk of airway compromise.
With the exception of simple, rapidly reversible hypoglycemia.
Exactly. And any significant traumatic brain injury.
Ah.
A traumatic intracerebral hemorrhage is always critical care time. You're managing their ICP, their blood pressure, you're calling neurosurgery. That requires dedicated, complex management.
Okay. Here's one we constantly overlook, especially at BGMC where we see a lot of complex psych issues. Number 5, psychiatric emergencies.
This only counts if your management involves an intervention to prevent life-threatening deterioration or a physiological collapse.
So not just an anxious patient.
No. For an agitated or combative patient, it qualifies if you have to give aggressive sedation like iamgeodon by itself, or the combo of IM Haldol plus a benzo and an antihistamine, or you have to use ketamine for a chemical takedown.
Yeah.
Using physical restraints might also qualify, but only if the risk is truly life-threatening.
So we have to document the physiological risk, not just the behavior.
Precisely. You have to document the imminent risk to life. For example, patient has excited delirium, temp of 102.5, profound agitation, placing them at imminent risk for cardiac collapse or rhabdo. Or patient highly combative, posing immediate severe threat of self-harm requiring chemical restraint. The moment you dedicate 30 minutes to aggressively stabilizing that patient to prevent a physiological catastrophe, that is critical care.
Finally, number 6, trauma. The less obvious trauma patient who isn't a full code.
They qualify if they need frequent dosing of pain meds, so 2 or more doses, and they're getting IV fluids for aggressive stabilization. Think a bad hip fracture or multiple rib fractures where you're trying to prevent respiratory distress. They also qualify if they get O-negative blood or 2 or more blood products for hemorrhage.
Or any trauma patient with unstable vitals, altered mental status with a GCS under 12, or anyone who needs to be transferred to a higher-level trauma center. The time you spend stabilizing them for that transfer is highly complex critical care.
The takeaway from this whole section is that the intervention itself, the BiPAP, the DKA drip, the 2+AVI antihypertensives, the blood transfusion, the chemical sedation, that is the clinical flag. That should immediately signal to you that you need to be thinking about CC time documentation, no matter what the final outcome is.
Okay, so now we shift to the most crucial step, the documentation. We've done the work, we spent the 45 minutes on the CHF patient, but this is the point where all that work gets lost because we don't translate it into the right language for coding.
We need 3 required documentation elements in the chart to close the loop effectively at Banner Gateway. This is how we make sure our work doesn't just feel critical, but is actually recognized as critical by coders and auditors.
Okay, element 1, define the critical condition.
You have to explicitly document why the patient was critically ill. Detail the high-risk condition or the organ failure. And a pro tip here is to use specific lab or physiologic data. Don't just say patient was sick and hypotensive.
Right.
Say patient was hypotensive to SBP 70s despite 2 liters of fluid and required immediate pressor consideration. Or patient was hypoxic to 86% despite 4 LNC, demonstrating acute respiratory failure.
We talked about being precise with the final diagnosis in the EHR. Why does that matter so much?
Because a vague diagnosis often triggers denials. Avoid general terms like altered mental status or confusion. Use definitive terminology that shows organ failure, like hypoxic respiratory failure or acute metabolic encephalopathy. The specificity supports the severity of the service you're billing for.
Element 2, detail the interventions. Prove that high-complexity decision-making was actually involved.
You need to show active management, not just passive monitoring. State that you reviewed and interpreted the cardiac monitor and the pulse oximetry in your MDM. This proves you are putting in continuous cognitive effort.
And we have to overcome the dynamic charting pitfall here, right?
Yes. This is so crucial at Banner Gateway.
Yeah.
You have to remember that just ordering meds, labs, or x-rays does not automatically pull that information into your MDM in a coherent story. You have to actively type or use Dragon to dictate the patient's course, what you did, and how they responded.
We have to write the narrative of the crisis and how we averted it. Link the acuity to the intervention.
Exactly. You need strong, concise sentences. Look at this example from our source material. It synthesizes everything. The patient was hypoxic to 86% despite being on her home oxygen requirement of 2 LNC. She was given an hour-long albuterol SVN, IV Solumedrol, and her oxygen was increased to 4L with improved saturations to 91%. The patient required continuous cardiac and pulse oximetry monitoring with reevaluation every 10 minutes for signs of fatigue and impending intubation.
That covers condition, intervention, response, and time.
Perfect.
Yeah.
So element 3, document the total critical care time. This has to be documented as a set time in minutes, not a range, never just a long time was spent. You have to write 52 minutes. And if you use a macro or a smart phrase, you must customize it with the exact number of minutes. Remember, 99291 covers the first 30 to 74 minutes. If you had 75 minutes, you use 99291 plus the add-on code 99292.
And we should explicitly include that exclusion statement for compliance, right?
I highly recommend it. It's like a built-in audit defense. A good, compliant documentation example should look something like this.
Okay.
Total time. I personally provided 45 minutes of total critical care time on direct and indirect patient care activities on the date of this encounter, exclusive of time spent on other independently reportable service procedures such as central line placement or intubation. Due to the high probability of clinically significant life-threatening deterioration, acute respiratory failure secondary to CHF exacerbation, the patient required my direct and personal management, including BiPAP titration, IV Lasix administration, and continuous monitoring.
That one little block covers all 3 requirements and basically signals to the coders this is legitimate.
Yep. Now, let's address the reality of team-based care at Banner Gateway. We rely so heavily on our PAs and other APPs. So what about shared time and APP integration?
Okay, so if a physician and a PA in our group both provide critical care to the same patient on the same day, how do we bill that?
Their time is combined. This is crucial. The time is pooled together, and only one provider, usually the physician, can report the initial 99291. You can't both bill for that first code.
So if the PA documents 20 minutes of dedicated critical management, and I spend another 30 minutes on the phone with specialists and writing the complex note, that's 50 minutes combined, and I bill the 99291.
Exactly. It's a team effort, and it's billed as a single block of team time.
That's a practical workflow for us. What about the teaching physician role? If I'm working with a resident, how do I document the time to make sure it's compliant?
Yeah, this is a huge Medicare hot button. Attending physicians have to document their personal involvement and the time they spent, and they have to agree with the management. Time spent by the resident alone does not count toward your critical care time. You have to use specific attestation language. The attending has to explicitly state they were personally present, supervising, and that they are claiming X minutes of time.
So the chart has to reflect not just the total 45 minutes of care, but my explicit personal involvement in that care.
Absolutely.
Yeah.
The attestation has to show you agreed with the plan and that you were there for the key decisions. If the resident documented 45 minutes, but you only document 15 minutes of direct face-to-face supervision, the practice can only bill for your 15 minutes. Unless you also document the other time you spend doing indirect stuff like consulting or charting, you have to explicitly attest to the time you personally spent. That distinction is critical for compliance.
Okay, this deep dive has clearly shown me that we are overwhelmingly under-documenting, not overbilling. The core issue isn't a lack of skill, it's just failing to recognize the high risk and then document the interventions and the time clearly. This isn't about padding charts. It's about accurately reflecting the crazy complex work we do every day at Banner Gateway.
Absolutely. The goal is accuracy, compliance, and capturing appropriate reimbursement for the intensive work we're already doing. I mean, the patient gets the life-saving care, and the practice gets the accurate billing that supports those high-acuity services. It's a win-win.
So as you head into your next shift at Banner Gateway, we want to leave you with 3 practical tips, 3 mental shortcuts to immediately improve your critical care capture.
Tip number 1, ask the 4 core questions. When you step away from that sick patient, the CHF, the DKA, the hyper-K patient, before you sign the chart, just pause and ask yourself, is an organ system acutely impaired? Is there a high risk of life-threatening deterioration? Did I do an aggressive high-complexity intervention? And did I spend more than 29 minutes of dedicated time? If it's yes to all 4, stop and document CC time.
Tip number 2, explicitly carve out procedures. Mentally subtract the minutes you spent on big, separately billable procedures, intubation, central lines, chest tubes. Only document the remaining critical management time and make sure you have separate detailed procedure notes. Remember that 40 procedure U difference we talked about. Separating the procedure from the time is financially protective and necessary.
And tip number 3, name the critical condition correctly. Do not use vague language like AMS. Use specific diagnoses that reflect organ system failure, hypoxic respiratory failure, acute metabolic encephalopathy, hypertensive emergency, and always include objective data, the SBP, the lactate, the GCS, the monitor review, to prove the complexity and instability that justified your management.
Excellent advice. Recognizing the critical state is the first battle. Documenting the time and interventions is how we win the war for accurate billing.
Critical care billing is complex for sure, but mastering this is just the entry point into a proper billing strategy. For next time, we need to dive into a topic that affects successful reimbursement even more than you think, even if your critical care note is perfect.
Oh, really? What else could possibly be more important than the critical care time note?
We need to understand why the specific ICD-10 codes, the diagnostic codes we assign, are so much more important than you realize, and how choosing a poorly supported code can trigger an instant denial, even if your 99291 documentation is meticulous.
Ah, so it's all about linking the severity of the service to the severity of the diagnosis.
You got it.
Now that sounds like a deep dive that will definitely keep us awake. Thank you for joining us for this high-yield deep dive into critical care time. We'll catch you next time.